Welcome back to the Deep Dive. Today we're shifting gears a little. We are not just exploring a topic for casual curiosity. We are stepping into the exam hall.
That's right.
Specifically, we are locking in on the MD Anesthesiology postgraduate exams for Gujarat University. And if you're an exam-going student, well, you know exactly what's at stake here.
Absolutely. This isn't just about passing a theory paper. This is, and I mean this, the absolute bread and butter of our specialty. If you can't manage a pregnant patient safely, you simply cannot call yourself an anesthesiologist. It is that fundamental.
The stakes are definitely high, and the source material we have today is, well, it's dense. We're synthesizing the heavy hitters, Miller, Morgan, Stolting, and a few key clinical manuals. Our mission today is to build the perfect answer for a very specific and very common exam question. Describe the physiological changes in pregnancy and their anesthetic implications.
It's a classic. A 20-mark long answer question, guaranteed. It shows up as short notes. It will 100% be a station in your Viva Voce.
So there's no escaping it.
None. And honestly, it's one of those topics where the examiner expects fluency. You can't stutter through the cardiovascular changes. You need to know the numbers, the mechanisms, and most importantly, why it changes your anesthetic plan.
Okay, so let's set the stage. When we talk about pregnancy physiology, it's not just about a baby growing. We're talking about a complete systemic overhaul of the mother's body. How do we define that for an exam answer?
You need to frame your answer by defining it as a sort of complex interplay of two main drivers. First, hormonal effects, and second, mechanical effects.
Okay. Hormonal and mechanical.
Right. On one hand, you have this massive surge progesterone and estrogen. They alter everything, smooth muscle tone, vascular sensitivity, you name it. And on the other hand, you have the simple mechanical reality of a gravid uterus pushing everything up and out of the way.
And the why here is critical, right? This isn't just trivia to fill pages in an answer booklet.
Exactly. The reason we care is that these changes explain everything. They explain why a pregnant woman desaturates in seconds during induction. They explain why they bleed differently, why our drug doses have to change.
So a standard dose for a spinal could be dangerous.
It could lead to a total spinal or cardiac arrest if you're not careful. It dictates our entire management strategy from the moment that patient wheels into the OT.
So for the student listening right now, visualizing their answer sheet, we're going to structure this exactly how an examiner wants to see it. We'll start with the introduction, then a rigorous system-wise breakdown.
System by system.
Then we'll cover obstetric specifics, and finally, exam integration, how to actually write it down.
That is the winning format. Structure is everything in a long answer.
Okay, let's dive in. The biggest system first, the cardiovascular system. This is extremely high yield. I think everyone knows blood volume goes up, but looking at Miller and the ARC guidelines, the numbers are specific. What are we quoting?
You quote that total blood volume increases by about 45 to 50%. And this starts remarkably early, around 6 weeks, and it peaks by the early third trimester.
45 to 50% is a huge increase.
It is. But here's the nuance, and this is what separates a pass from a distinction. It's not a balanced increase. The plasma volume, the watery part, increases by about 50%. But the red cell mass only goes up by about 20 to 30%.
So you get a dilution effect.
Exactly. We call it the physiological anemia of pregnancy. You're essentially watering down the soup. The hemoglobin concentration drops to around 11 or 12 grams per deciliter.
And that's considered normal.
It's normal, and physiologically, it's actually brilliant. It decreases blood viscosity.
So the blood is thinner.
Right, which improves flow dynamics through that low-resistance uteroplacental bed. It's an evolutionary rheological advantage. It helps get blood to the baby.
But there has to be a limit. If a student sees a hemoglobin of, say, 9 or 10 in a pre-op check,
then that is not physiological anymore. That requires investigation. That's pathological anemia, and you need to be able to draw that line for the examiner.
Got it. Okay, so moving to the pump itself, cardiac output. With 50% more blood, the work has to increase.
And it does, massively. Cardiac output increases by 40 to 50%. It's a huge load on the heart. This starts early, by 8 weeks, and plateaus around 28 to 32 weeks.
And is that mostly from the heart beating faster or pumping more with each beat?
It's both, but the timing matters. Early in pregnancy, it's mostly the stroke volume increasing by about 30%. Later on, the heart rate creeps up by about 15 to 25%.
So a resting heart rate of 90 isn't unusual.
Not at all. A baseline of 70 can easily become 85 or 90. But here's where it gets really interesting for us as anesthetists: labor.
The danger zone.
The absolute danger zone. During labor, Every single uterine contraction squeezes about 300 to 500 milliliters of blood from the uterus back into the maternal circulation. We call it auto-transfusion.
Like an internal fluid bolus.
Precisely. And it pushes cardiac output up by another 15 to 45% depending on pain and anxiety. But the absolute peak, the moment of maximum stress, it's immediately postpartum.
Right after the baby is delivered.
Yes. The moment the baby is out, two things happen. One, the uterus clamps down, causing a massive auto-transfusion, way more than during a contraction. Two, the caval compression is suddenly relieved. The result: you get an 80% increase in cardiac output compared to pre-labor values.
80%. That is a staggering number.
It is. And this is the moment a patient with valvular heart disease, like mitral stenosis, will go into acute heart failure. Their heart just can't handle that volume load.
So if the examiner asks, when is the heart most stressed?
The answer is immediately postpartum. If you say during pushing, you're wrong. It's that moment of autotransfusion.
Now here's the paradox.
Yeah.
We have all this extra blood, the heart is pumping like crazy, but the blood pressure actually falls mid-pregnancy. That seems counterintuitive.
It does, but you have to remember the hormonal driver we mentioned at the start. Progesterone and prostacyclin are potent vasodilators. They relax the smooth muscle of the blood vessels.
And the placenta.
And the placenta is essentially a giant, low-resistance arteriovenous shunt. It's like adding a huge drain pipe to the system. So the systemic vascular resistance, or SVR, drops by about 20%. This drop in resistance more than makes up for the rise in cardiac output.
So blood pressure, especially diastolic, dips mid-pregnancy and then returns to baseline at term.
Correct. Which means if you see a normal blood pressure of 120/80 in the second trimester, that might actually be high for that specific patient. You have to think relatively.
Okay, we have to talk about supine hypotension syndrome. This is a classic. Aortocaval compression. What's happening mechanically?
This is simple anatomy, but it's critical physiology. The inferior vena cava and the aorta run right along the spine. When a woman at term lies flat on her back, that heavy, gravid uterus sits directly on top of them.
It just squashes them.
It squashes the IVC against the vertebrae. It's a mechanical blockage.
So venous return to the heart is cut off.
Precisely. Venous return drops, so stroke volume drops, and cardiac output can fall by 10 to 20% instantly. Now, in a healthy, awake woman, she compensates.
She might feel a bit sick or dizzy.
Right, that's the Pacero sign.
Yeah.
But her sympathetic nervous system kicks in. It clamps down on the peripheral vessels, increasing SVR to keep the blood pressure up, and blood finds alternate routes, like the azygos veins.
But here is the anesthetic danger. We take that same patient and we give her a spinal anesthetic.
And disaster strikes. A spinal creates a sympathectomy. You knock out her only compensatory mechanism, that vasoconstriction. So now she has a blocked IVC and profound vasodilation from the spinal.
The blood pressure just bottoms out.
It crashes. That is why we never, ever let a pregnant patient lie fully supine after about 20 weeks. You must use a wedge under the right hip or tilt the whole table to the left.
And why the right hip specifically?
Because the IVC sits slightly to the right of the spine. We need to displace the uterus to the left, to literally roll it off the vessel. That's a favorite Viva question. Doctor, why the right hip? It shows you know your anatomy.
Just before we leave the heart,
Yeah.
What about auscultation? If I'm listening to a pregnant patient's heart, what sounds are normal?
Good question. Because of the high flow and volume, you'll often hear a split S1, and up to 84% of pregnant women will have a loud S3 gallop. A systolic flow murmur is also very common.
So you shouldn't be alarmed by those.
No, don't let an examiner trick you into thinking it's heart failure based on those signs alone.
However, a diastolic murmur is almost always pathological. If you hear a rumble in diastole, you should be thinking mitral stenosis, not pregnancy.
Okay, great. Let's move on to the respiratory system. This is another area where, the physiology really works against the anesthetist.
It really does.
Let's start with the metabolic engine, the demand for oxygen. It's skyrocketing. Oxygen consumption is up by 20 to 35% at term. That's to feed the fetus, the placenta, and the increased maternal metabolic rate. And it goes even higher during the stress of labor, so the engine's burning fuel much, much faster.
And what about the fuel tank? The oxygen reserve?
The tank shrinks. This brings us to the functional residual capacity, or FRC. This is the single most important respiratory concept in obstetrics. You must mention this.
Okay, so FRC, that's the air left in your lungs after a normal breath out.
Exactly. It is your oxygen reserve.
Yeah.
In pregnancy, that gravid uterus pushes the diaphragm cephalid upwards by about 4 centimeters. It just squishes the lung bases.
So FRC has to drop.
It drops significantly, by 20% when standing and up to 30% when supine. And remember that FRC is where we store oxygen during apnea.
So you have a smaller oxygen tank and a faster burning engine.
That's the double whammy. It's the perfect storm. This is why if a pregnant patient stops breathing during the induction of general anesthesia, they desaturate incredibly fast.
So we don't have that normal buffer.
You don't have the standard 3 to 5 minutes of safety you might have in a non-pregnant adult. You have seconds, maybe a minute, tops, before severe hypoxia sets in.
And what about the ventilation parameters themselves? Is she just breathing faster?
That is a very common Viva trap. The respiratory rate actually changes very little, maybe an increase of 1 or 2 breaths per minute. But the minute ventilation, the total amount of air moved per minute, goes up by nearly 50%.
50%? And how?
It's driven almost entirely by an increase in tidal volume. They take deeper breaths, not necessarily faster breaths.
And that's progesterone again.
Yes, progesterone acts as a direct respiratory stimulant. It makes the respiratory center in the brainstem more sensitive to CO2. It's basically telling the body, we need to blow off more CO2 to create a gradient for the baby to offload its waste products.
So the maternal pad O2 drops.
It drops from a normal of 40 down to about 30 or 32 millimeters of mercury.
Which means they're in a state of chronic respiratory alkalosis.
They are, but the kidneys are smart. Over time, they compensate by excreting more bicarbonates. The pH stays nearly normal, maybe slightly alkalotic at 7.44, but the bicarb level is low, around 20.
And the anesthetic implication there is huge for our ventilator settings.
It is absolutely crucial. If you intubate a pregnant woman, say for a C-section under GA, and you set the ventilator to normal to get a CO2 of 40, you are actually hypoventilating her relative to her baseline.
And that's bad for the fetus.
It's terrible for the fetus. You remove that favorable CO2 gradient and you can cause a profound respiratory acidosis in the baby. You must aim for their normal PACO2 around 30 to 32. Do not normalize it.
And what about the airway anatomy itself? It's not just the lung volumes that change, right?
No, the airway is, it's a minefield. Estrogen causes massive capillary engorgement of the entire respiratory mucosa, the nasopharynx, the larynx, the trachea. It's all swollen and boggy.
Which means it bleeds easily.
Very easily. It's incredibly friable. If you try to pass a nasal airway or an NG tube, you can cause a torrential nosebleed. The advice is simple. Just avoid the nose if you can. And during intubation, the glottic opening itself might look smaller because of the edema. You have to be gentle.
Okay, let's shift to the hematological system. We mentioned the anemia, but what about clotting? This is massive for us.
Right. Pregnancy is a hypercoagulable state. And evolutionarily, this makes perfect sense. The body is preparing for the controlled hemorrhage of delivery.
Getting ready to stop the bleeding.
Exactly. So almost all the procoagulant factors go up. Fibrinogen, which is factor 1, it doubles. It goes from 200, 400, 400, 600. Factor 7, 8, 9, X, 12, all increased.
Is anything decreased to balance that out?
Yes, a few things. Factor VII and factor 13 decrease. And crucially, some of the natural anticoagulants, like antithrombin III and protein S, also decrease.
So the net effect is a very strong tendency to form clots.
A very strong tendency. This puts the mother at a much higher risk for deep vein thrombosis, DVT, and pulmonary embolism. And PE is still a leading cause of maternal mortality. You have to be vigilant.
What about platelets? Do they change?
The count is usually normal, but it can be a bit lower. This is due to dilution and also increased consumption in the placenta. We call it a gestational chromatocytopenia.
And that's usually not a problem.
It's usually benign, yes. If the platelet count is above, say, 70 or 80,000 and she's otherwise healthy, we generally feel safe proceeding with neuraxial blocks, but you must check the count before you put a needle in their back.
Which is a good transition to the gastrointestinal system. This is where the old rule, always treat as a full stomach, comes from.
Correct. And it's really a two-pronged attack. First, there's the mechanical issue. The uterus pushes the stomach upwards and changes the angle of the gastroesophageal junction, basically flattening it out.
Making reflux easier.
Much easier. And second, the hormonal issue. Progesterone relaxes the lower esophageal sphincter, the LES, so the barrier that's supposed to prevent reflux is weak.
And does the stomach actually empty slower? I've heard that's debated.
It is debated. In a normal, non-laboring pregnant woman, gastric emptying is probably not significantly delayed. But the moment labor starts, or the moment she gets opioids for pain, digestion effectively stops. Gastric stasis becomes profound.
So for us, for anesthesia, after about 12 to 20 weeks of gestation, we just consider them a full stomach risk no matter what.
Always. No exceptions. That means rapid sequence induction, or RSI, with cricoid pressure if we are doing a general anesthetic. And we always give aspiration prophylaxis sodium citrate to neutralize the acid, an H2 blocker, maybe metoclopramide.
Because we're terrified of Mendelssohn syndrome.
Exactly. Acid aspiration pneumonitis. Even for a scheduled elective C-section, we treat them as if they just ate a 4-course meal.
Okay, let's move up to the central nervous system.
Yeah.
How does the pregnant brain react to our anesthetic drugs?
It becomes much more sensitive. The MAC, or minimum alveolar concentration, for our inhalational agents like sevoflurane drops by 30 to 40%.
That's a huge reduction. What's the mechanism behind that?
It's likely multifactorial. It's partly due to the sedative, sort of hypnotic effects of progesterone, which acts on GABA receptors, much like a benzodiazepine. And it's also due to increased levels of natural opioids, like beta endorphins.
So if you run a standard non-pregnant dose of gas,
You will overdose them, you'll cause profound hypotension, and they'll be very slow to wake up. You have to dial it back significantly.
and what about the local anesthetics we use for spinals and epidurals?
The same principle applies. The nerves themselves are more sensitive to local anesthetics, the onset of the block is faster, and the toxicity threshold is lower. You simply need less drug to get the same effect.
But this segues perfectly into the renal system. It sounds like the kidneys are just working overtime.
They are super kidneys in pregnancy. Renal plasma flow and the glomerular filtration rate, or GFR, both increase by about 50%. They are filtering the blood incredibly aggressively.
Which means they clear waste products faster.
Right, so blood levels of urea and creatinine drop. A normal creatinine in a pregnant woman is around 0.5 or 0.6 milligrams per deciliter.
So if I see a patient with a creatinine of 0.9 or 1.0,
Alarm bells. That's a huge red flag.
yeah.
That indicates significant renal impairment in a pregnant patient, even though it looks normal for a non-pregnant person. That is a classic exam trap. They'll give you that value and ask if it's okay. The answer is no.
And because they're filtering so much. What about glucose?
The renal tubules just can't reabsorb all the glucose that's being filtered. The threshold is lowered. So glycosuria sugar in the urine is seen in up to 40% of pregnant women. It doesn't automatically mean diabetes, but you absolutely have to rule it out.
Speaking of diabetes, a quick word on the endocrine and metabolic changes.
Well, pregnancy is what we call a diabetogenic state. The placenta produces hormones like human placental lactogen, or HPL, and also cortisol. These hormones cause insulin resistance.
Why does the body do that?
The mother needs to keep her blood sugar slightly elevated to make sure there's enough glucose to get across the placenta to feed the fetus. But this can push her toward gestational diabetes if her pancreas can't produce enough insulin to keep up with the resistance.
And metabolically.
It's a state of accelerated starvation. Because the fetus is a constant drain on glucose, if the mother fasts for even a short period, she switches to fat metabolism very quickly. He can become ketotic much faster than a non-pregnant patient.
Okay, we've covered the general systems. Now let's get into part C of our outline, obstetric-specific considerations. We've touched on the airway, but let's really drill down. Why is the difficult airway such a huge deal here?
Because the incidence of failed intubation is 7 to 10 times higher in obstetrics than in the general population. 7 to 10 times.
That's a terrifying statistic.
It is. We've talked about the edema.
Yeah.
But you have to add to that other factors, like enlarged breasts, which can obstruct the laryngoscope handle. You literally can't get the angle right to insert the blade. Then there's weight gain and general obesity.
And I read that the Mallampati score can actually change during labor.
It does. This is fascinating and terrifying. A woman might walk into the labor ward as a Mallampati class 2, but after 12 hours of pushing, 4-feet fluids, and, screaming, the airway swells even more. She can easily become a class 3 or even a class 4.
So you have to reassess.
You must reassess the airway right before you induce. You cannot rely on the assessment that was done on admission 12 hours ago. It's not valid anymore.
So practically, what does that mean? Smaller tubes?
Always have a 6.0 and a 6.5 millimeter endotracheal tube ready. Have a short handle laryngoscope available. And you must have a backup plan ready and open on the trolley, a bougie, a video laryngoscope, and LMA. You need plan A, B, and C.
Okay, let's talk about placental physiology. This concept is core to fetal survival. The blood flow to the uterus is massive. We're talking 700 to 900 milliliters per minute at term. But is that flow regulated?
No, and this is the key concept you must write in your exam answer. The uteroplacental vessels are maximally dilated at term. They have no capacity for autoregulation. Flow is strictly pressure dependent.
So flow equals pressure divided by resistance.
Exactly. And since the resistance is fixed at a very low level, if the mother's blood pressure drops, uterine blood flow drops linearly with it. There's no buffer for the fetus.
So maintaining maternal blood pressure is our absolute #1 priority during any anesthetic.
It is everything.
Well,
If mom's pressure drops, the baby effectively holds its breath. We have to treat any hypotension immediately and aggressively.
and fetal oxygenation depends entirely on this flow.
100%. The fetus does have a trick up its sleeve, though. Fetal hemoglobin, HbF.
Right, it holds on to oxygen tighter.
It has a much higher affinity for oxygen than adult hemoglobin. It shifts the oxygen dissociation curve to the left. It essentially rips oxygen away from the mother's blood in the placenta, but it can only grab what is delivered. If the flow stops, that affinity doesn't matter one bit.
Let's move into part D. The anesthetic implications, all in one place. We've hinted at these, but let's synthesize them. First, for regional anesthesia spinals and epidurals. We know we have to reduce the dose, but why exactly?
There are two main reasons. One is the biochemical reason we mentioned. The nerves are just more sensitive. But the second is a mechanical reason.
Okay.
Remember the supine hypertension, the IVC is compressed, the venous blood has to find another way back to the heart. A lot of it diverts into the epidural veins, a network called Batson's plexus.
So the veins in the epidural space get huge and swollen.
Correct. They become engorged. And that eats up space inside the spinal canal. It compresses the dural sac, which makes the subarachnoid and epidural spaces smaller and tighter.
So if you inject your standard dose,
It spreads much, much higher and faster because the space is smaller. That's why you have to reduce your dose by about 30% to avoid a high spinal that could paralyze the respiratory muscles.
and managing the hemodynamics of that block.
You have to be proactive. A spinal causes a sudden sympathectomy, a sudden vasodilation. If you add aortocaval compression on top of that, the pressure will crater. So the drill is 1, left uterine displacement, always. 2, co-load with IV fluids. And 3, have your vasopressors ready to go.
And the vasopressor of choice now is phenylephrine, not ephedrine.
Yes, that has changed. Historically, we used ephedrine. We thought pure alpha agonists like phenylephrine might constrict the uterine arteries. But modern research shows that phenylephrine is actually better. It maintains maternal blood pressure very effectively and, crucially, causes less fetal acidosis than ephedrine.
Interesting.
Ephedrine crosses the placenta and can speed up the fetal metabolism, which isn't ideal. So today, phenylephrine is the go-to.
Okay, now for general anesthesia, we try to avoid it, but sometimes it's necessary for extreme fetal distress or a major maternal hemorrhage.
When you have to do it, speed and safety are the goals. RSI is mandatory. Pre-oxygenation is absolutely non-negotiable. Remember that low FRC and high oxygen consumption.
And you'd position them sitting up a bit.
Yes, you ramp the patient up, head elevated. This helps increase the FRC little and makes the view for laryngoscopy much better.
And for drugs, anything special?
Propofol or thiopentone are fine for induction. Succinylcholine or succinylmethonium is still the standard for RSI. There's a theoretical point that plasma cholinesterase levels drop by about 25% in pregnancy, which means succinylmethonium might last a tiny bit longer, but clinically it's irrelevant. You still use the standard full dose. Do not underdose it.
Okay, fantastic. Let's get to Part E, exam integration. We are sitting in the exam hall. We have 20 minutes for this question. How do we structure it on the page to impress the examiner?
Don't just write a wall of text. Examiners love tables. I would make a table with 3 columns. Column 1, system, so CVS, respiratory, etc. Column 2, the change, for example, cardiac output increases 50%. FRC decreases 20%. And column 3, the most important one, anesthetic implication.
So for FRC decreases, the implication would be rapid desaturation during apnea.
Exactly. Anticipate difficult intubation, risk of high spinal. Connecting the change to the action, that's where the marks are.
And what about diagrams?
Absolutely draw diagrams. Draw the lung volume diagram. It's easy. Just show a normal lung volume chart and then draw one next to it for pregnancy, showing the FRC shrinking while the vital capacity stays the same. It takes 30 seconds and scores high marks.
Anything else to draw?
You could draw the flow volume loop. And the key there is to show that the shape of the loop doesn't change. It just shifts to the left. That shows the examiner you understand that airway resistance isn't the primary problem. It's the reduction in volume.
Let's talk about the Viva. What are the traps they're going to set for us?
We've mentioned a few. The respiratory rate trap is a classic. They'll ask, so, doctor, is the pregnant patient tachypneic? And the wrong answer is yes.
The right answer is?
No, sir, ma'am. The respiratory rate is largely unchanged. The increase in minute ventilation is primarily driven by an increase in tidal volume.
Okay, another trap.
The creatinine trap. This patient has a creatinine of 0.9. Is her renal function normal? The answer is a definitive no. That suggests significant renal impairment in the context of pregnancy.
And the cardiac one we talked about.
When is the patient with pre-existing heart disease at the greatest risk? Immediately postpartum. If you say, during the second stage of labor, you'll lose points. It's that massive auto-transfusion after delivery that overwhelms a compromised heart.
And simple anatomy question to finish.
Why do we put a wedge under the right hip? You need to be able to confidently explain that the IVC lies to the right of the vertebral column, and displacing the uterus to the left is what's required to decompress it.
Perfect. So let's summarize. If we had to distill this entire deep dive into a final call to action for the exam.
You need to think of pregnancy as a maximal stress test on every organ system. It's a state of accelerated starvation metabolically, it's hypercoagulable hematologically, it's high flow, low resistance cardiovascularly, and low reserve respiratory-wise.
And the anesthetist mantra throughout all of this.
Safety first. You are caring for two patients, but you must prioritize the mother. Maternal resuscitation is fetal resuscitation. If the mother has no blood pressure and no oxygen, the fetus has nothing. So, you secure the mother's airway, you maintain her pressure, and for God's sake, you tilt the table.
You know, this raises a provocative thought to end on. We spend so much time learning normal physiology versus pregnancy physiology. But if you just look at a pregnant patient at term, she's tachycardic, she has flow murmurs, she has peripheral edema, she's anemic, she gets short of breath walking to the bathroom.
If a non-pregnant patient walked into your clinic with that constellation of signs and symptoms, you'd be admitting them for an urgent workup for congestive heart failure or some other major pathology. The real art of obstetric anesthesia is being able to distinguish the physiological adaptation from the impending pathological disaster. Knowing when that shortness of breath is just the effect of progesterone on the respiratory center, and when it's the first sign of a life-threatening pulmonary embolism, that's the skill.
That is the challenge.
Yeah.
All right, for everyone listening, go grab a piece of paper right now. Draw that lung volume diagram. Visualize the FRC shrinking. Visualize the uterus compressing the IVC.
And remember the tables. System, change, implication. That's your key to passing. Good luck with the Gujarat University exams. You've got this.
We'll see you on the next Deep Dive.